Okay, so I've got the green light from my esteemed colleague, Tracy Glynn, and welcome to everybody. Great to be with you on this beautiful summer day. Thank you very much for joining us. Merci à toutes et à tous de vous avoir joint à nous pour discuter de la privatisation et de la profitisation des soins de santé. Ce webinaire se déroulera en anglais, mais on pourrait prendre vos questions en français dans le Q&A. Et on essaiera de faire justice avec ça. So I'm Anne Lagacé Dowson. I am the Media and Communications Director at the Canadian Health Coalition, former journalist at CBC, and I'm speaking to you from Tiohtià:ke, also known as Montreal, the unceded territory of the Kanien'kehá:ka people of the Haudenosaunee, the Mohawks of the Six Nations Confederacy. And today we're going to talk about runaway privatization and what can be done about it with three dynamite people who work on these files and have done for a while. We're very happy to have them with us today. Natalie Mehra, the Executive Director of the Ontario Health Coalition, who's going to talk to us about their great work on complaints with regard to cataract surgery. Mary Boyd, I'm talking to you in PEI. This is one of Mary's big issues. And she was one of the instigators of this webinar. Andy Longhurst is joining us from somewhere in camping country in BC. He is a researcher and policy expert on privatization and other healthcare issues, published by the Parkland Institute, and he's a PhD candidate at Simon Fraser. Thank you very much for joining us on vacation, Andy. And Melanie Bechard, also joining us from Ottawa. She's an emergency room pediatrician at the Children's Hospital of Eastern Ontario and president of the Canadian Doctors for Medicare. So you can see a good cross-section of our wonderful activists and researchers. So I'm going to start with you, Natalie. You'll be leading the charge on Monday and Tuesday, among other things, at the Premier's meeting in Huntsville at the Deerhurst Resort, where many of us will be joining you. There are panels and car cavalcade and a protest, bonfires, wolf howling. But anyway, right now we're going to talk about what the CHC is doing to fight runaway privatization, and tell us about this 50 complaints strategy that you've launched, because it's very impressive and made it into the news. So I'll hand it over to you, Natalie, and we'll give you about 15 minutes, and I might just come back at you because I know there's so much to say.
Perfect. Thank you very much, Anne. And thanks everyone for joining. So a few weeks ago, we issued a formal complaint from 50 patients who had been extra billed in various ways when they went in for either diagnostic tests or surgeries. Specifically, they were MRIs, cataract surgeries, and in one instance, gender reassignment surgery. And so mostly in Ontario, the private surgical diagnostic clinics are cataract surgery clinics. We have a couple MRI, CT clinics, but mostly it's cataract surgery clinics. At this point in Ontario, we don't have private for-profit joint replacement clinics and so on like you do in BC, for example, or in Quebec. And so where we see the violations of the Canada Health Act are in those clinics. And so just to be really super clear, under the Canada Health Act, all medically necessary hospital and physician services are covered. That means OHIP or your provincial health plan, MSP in British Columbia or RAMQ in Quebec or what have you, cover all medically necessary services. That's a requirement of the Canada Health Act. And if the province doesn't ensure that, then they're supposed to have money clawed back from their, as a penalty from their transfer payments. In Ontario, what we're seeing is just an absolute kind of wild west among the private clinics where they are selling cataract surgeries. And what we're seeing is patients who are being just outright extra billed. So the Canada Health Act prohibits extra billing. That means the physicians are charging OHIP or the public plan in your province and charging patients on top. Illegal. It bans user fees as well. You cannot charge a patient a user fee for a medically necessary surgery or MRI or CT, what have you, lab tests and so on. And so they're just flagrantly extra billing. Patient goes into a private clinic and no one tells them that there's an OHIP covered option, which by the way isn't an option, that's the rule. And they're just charged thousands of dollars. Now, routinely, we're talking, $7,000, $8,000 for their cataract surgeries. They're also charged outright for extra eye measurement tests that are medically unnecessary, but they're not told that they're medically unnecessary. In fact, as patients, people should know that your eye measurement tests, your surgery, your eye drops to follow up, all of those things are covered by the public health plan, including the unique lens that your eye needs for cataract surgery. There is no basic lens. Every surgery is unique to the patient's eye. So either they face extra billing or manipulative upselling. So this is beyond just offering medically unnecessary stuff for extra money. The patient is told that the publicly covered way, i.e. OHIP in Ontario, is inadequate, has worse outcomes or poor outcomes, is basic, or that the extra lenses and stuff are better. All kinds of manipulative words to make the patient believe that if they don't buy that stuff, they're going to have a substandard surgery with substandard outcomes. Let me just be completely clear. For the eye measurement tests, the outcomes for cataract surgery are generally very good. When they decide what is going to be covered or not, there's kind of an expert panel, and they look at the efficacy. That is, does this treatment or diagnostic test provide better outcomes if you do it than if you don't do it? The eye measurement tests that aren't covered because they don't show efficacy. There's no better outcomes if you do them or don't do them, according to the expert panel. That's why they're not covered. The lenses that they're upselling to patients are often nothing to do with cataract surgery at all, but the patients are never told that. And so they go in for cataract surgery and they're told they'll have a better outcome if they get lenses that have to do with other optic correction, nothing to do with cataract surgery, some of which don't have great outcomes, some of which do have good outcomes. It's a buyer beware situation, but it's not medically necessary for cataract surgery. And the patients are manipulated into paying hundreds to thousands of dollars for that. They're also told that they're buying one thing, but the receipt shows something else. So patient goes in for an MRI because she needs it before an open heart surgery. She's charged $2,000 for the MRI. On the receipt, it says it's for contrast. Patient goes in for cataract surgery. They're told they're paying for the cataract surgery. On the receipt, it'll say it's for toric lenses for astigmatism or something else. So they cover up that they're extra billing the patients by issuing receipts for stuff that's medically unnecessary. And then some patients are told that the wait lists are 2 years or even 5 years in the public health system for cataract surgery. But if they pay, they can get this surgery within 2 weeks. And this is my last point in. And so the patients are fooled into believing that the wait times are really long. The truth is, in Ontario, we have a wait times website, and other provinces have tracking as well. And you can see that 80% of patients are being seen within 100 days. So just over 3 months, they're getting in for their surgery. Even the lowest priority patients are getting in within 4 months or so. Nobody is waiting 2 years for cataract surgery in the public health system. Possibly in some areas like Thunder Bay had bad waits the last time I looked, but you can check on the wait list yourself. So patients are being lied to and sold queue jumping. That is also unlawful under the Canada Health Act, which says that all Canadians, regardless of your wealth, have the right to healthcare based on your medical need and not how wealthy you are. No one's allowed to sell queue jumping. The lineup is based on need, and in fact, the lineup is often nowhere near as long as people are led to believe in order to get them to pay thousands of dollars to these private clinics. It's a travesty. So we have people who spent their life savings in their 70s to pay for their cataract surgery and no longer have savings for the rest of their life, right? Unless they go back to work in their 70s and 80s to pay for it. That should never happen in Canada. Our Medicare laws federally and provincially prohibit it. Provincially, it's illegal. Federally, it's unlawful, and it should not be happening. But it is happening in the private clinics. And just last thing, we did a study in 2007, 2008, and we repeated it in 2017, in which we called all the private clinics across the country that we could find, and we caught the majority of them extra billing and charging user fees. And we did it with the Globe and Mail, and the Globe and Mail found that the clinics were, a number of them were double billing. So billing the public health plan and billing patients too. And if you look at the numbers, if you charge, in our public health system in Ontario, it's about $500 per cataract surgery in the public system. That's what they get for a 7-minute surgery. Pretty good price. Ophthalmologists are very well paid. They might be making towards $1 million or more per year from their public billings alone. But if you charge each of your 1,000 patients a year $2,000 extra dollars, you're making $2 million a year on top. If you charge them $7,000, you're making $7 million a year on top. And that's why it's happening. It's just about greed.
Okay, thank you very much, Natalie. Great opening sort of remarks. There's a number of people who have already asked some questions, which we will get to after the speakers have given us their presentations. We'll go back to the Q&A. So I just mentioned if you have a query or a comment, to put them into the Q&A, and then I will bundle them and put them to our panelists. But thank you very much, Natalie. And maybe in the question period, we can talk about the fact that you're leading the charge on these 50 complaints, because I think that's a really interesting model for other taxpayers and citizens, but also healthcare coalitions across Canada. Okay, so our next speaker is Andy Longhurst, who looks like he's in a van there, I think, maybe, somewhere in the green province of British Columbia. So Andy Longhurst, over to you.
Thanks, Anne, and thanks to the CHC for hosting this. And really kudos to the Ontario Health Coalition and Natalie's work for leading the charge on what has become a pervasive and really problematic practice across the country. So what I'll do is provide a bit of a sketch, mainly of the experience in Alberta based on the research that I've done in that province as it relates to surgical outsourcing or private for-profit delivery of publicly funded services. And I'll probably from there kind of talk to some of how it extends and what we're seeing across other provinces as well. So in 2019, just to give people a sense of how things began, the former Premier Jason Kenney announced the Alberta Surgical Initiative. And it was an initiative intended to really create a much larger marketplace for the delivery of private surgical care with public dollars. And so I often refer to this as outsourcing or private delivery, but it's using public dollars to fund those procedures in investor-owned private for-profit facilities. And what we have seen, I've now done 2 reports on the situation in Alberta and the performance of that initiative. And what we have seen consistently from the first couple years of data and the initial report, and then the most recent report that came out earlier this year called Operation Profit, published by the Parkland Institute at the University of Alberta, what we have found is that contrary to the government's claims that this is about increasing capacity in the system, this is about reducing wait times, this is about more cost-effective delivery of surgical care, we have found none of those claims to be valid. And in fact, what we have seen is that over the first 5 years of that Alberta Surgical Initiative, where the primary focus has been using public dollars to build a for-profit surgical industry, which is, I think the intention is quite clear, is to make this a for-profit hospital industry. And what we have seen is that in those first 5 years, surgical volumes increased in the for-profit centers, and we saw a reduction in surgical activity or the volume of procedures performed in public hospitals. And what that tells us, and then when we also look at the administrative data around hospital staffing levels, we are seeing the movement of operating room staff out of public hospital facilities, or a reduction. So that shifting of the workforce. And this is not a new finding. We see this a lot in the literature in terms of the for-profit involvement in healthcare, where these facilities provide daytime opportunities for OR nurses, for surgeons, for anesthetists. It is for the surgeons in particular, the ability to perform procedures during the day, not have responsibilities necessarily into the evenings, or have to attend to, for the anesthetists, having challenges, having them provide coverage for emergency procedures and on call. So it's attractive, the money is good, and so we're seeing that shifting of the workforce, which explains why we're seeing a reduction in surgical activity in public hospitals. Now, keep in mind, public hospitals are the only place where more complex procedures and emergency procedures are performed. So we are seeing government policy purposefully shifting the easiest, most lucrative, most profitable patients and those procedures into these for-profit surgical facilities. Mainly, these are low acuity patients, low complexity orthopedics happening in hips and knees and other orthopedic procedures, as well as some general surgery, a number of other specialty areas. But the focus here is on the orthopedics and moving those simple routine procedures into these investor-owned facilities. So we have seen a net reduction in activity over the 5 years in public hospitals. We've seen an increase in activity in the for-profit facilities. And the result has been that in 9 out of 10 priority procedure areas tracked by the Canadian Institute for Health Information, we have seen over the 5 years of this initiative, we have seen wait times increase. And we have seen wait times increase in all of the areas of cancer surgery tracked by CIHI, the Canadian Institute for Health Information. And this is what we are hearing on the ground too. We are hearing from surgeons and physicians themselves. We are hearing from healthcare workers. We are hearing from other researchers that this shifting of your health human resources, your funding allocations that are favoring these investor-owned facilities, the effect of that is it is encouraging the selection of the most profitable procedures, again, to be performed in these facilities, to the detriment of patients who require more complex procedures to be performed in public hospitals. And the main challenge, and this extends across the country, when you outsource procedures to private for-profit facilities, is primarily your operating room nursing and your anesthetist workforce. They cannot be in two places at once. And so we have operating rooms and operating specialized operating room units across Alberta and across the country that are sitting idle and not used because we do not have the staff and the funding to perform procedures in that infrastructure that, keep in mind, taxpayers have already paid for. So on the point about this being more cost effective and cheaper, we found quite the opposite in Alberta. We have found that for most of the for-profit providers, the per unit procedure price is actually much, much higher than what it costs to perform them in public hospitals. And this is by the fact that these facilities have capital costs and they have a requirement to get a return on their capital invested. And so they do that by negotiating a per unit procedure price that far exceeds what public hospitals can perform these procedures within the public system, infrastructure that has already been funded and paid for by taxpayers. And so what we are seeing across this country and in Ontario as well, where we've seen it, being 2 to 4 times more expensive to perform the exact same procedure in an investor-owned facility than it costs to perform it in a public hospital. So on that ground of claiming that this is more cost-effective, it is an incredible waste of taxpayer dollars, the public's dollars, to be handing it over to for-profit investors, some of which are owned by private equity. Some of them are groups of surgeons who are investors in these facilities, other players. There were, in Alberta, we're still in the middle of allegations of corruption that involve a number of players and that involve the allegations from the former CEO of Alberta Health Services that there was contract padding or price padding of pushing contract prices up in these private for-profit facilities to give them a greater return. And so this is the kind of behavior that we are concerned about seeing across the country, where we see that profit making or profit taking is fundamentally hardwired into the business models of these facilities. And so when we look at the performance, when we look at claims about cost effectiveness, when we look at all of these issues around the movement towards outsourcing procedures with publicly funded dollars, we see it is not good value for money. And we also, on top of that, finally, just to speak to the concerns that Natalie is raising, I know my research across the country is also is showing that we're seeing the movement towards two-tier healthcare as these for-profit facilities also engage in extra billing, because at the end of the day, this is about maximizing revenue. And so if we're going to see Ontario proceed very quickly and more aggressively down this path with a commitment of $280 million over 2 years to for-profit facilities, we are likely to see this country paving the way to two-tier healthcare. And what we need to see is we need to see leadership from the federal government and a clear movement away from investor-owned for-profit delivery of healthcare. And I'll wrap up there. Thanks so much.
Thank you very much, Andy. So we started with Natalie at the micro level and Andy sort of more at the macro level. And in the conversation afterwards, we'll try and talk about strategies to try and counter this, because that's where a lot of people who've joined us today come in. But before we do that, I'm going to ask Dr. Melanie Bechard in Ottawa to talk to us a little bit about the work that the Canadian Doctors for Medicare have done. So welcome, Melanie.
Thank you so much, Anne. Nice to be here, everybody. I wanted to pass along some greetings from Dr. Bernard Ho, who's the Vice Chair of Canadian Doctors for Medicare. He was hoping to attend this webinar, but there was a time change, and he's actually gone on to school to work on his master's in public policy. So he couldn't be here, but I was very happy to step in at the last minute. Well, a week or two notice. Now, I'm going to start with this story, and it's going to seem completely unrelated, but I'll bring it back. So my husband, Gordon, is the oldest of 4 children. They're all very close in age. His child life was, I think, a little bit chaotic. And he had this plastic inflatable bat when he was a kid. And anyone who has siblings knows exactly what Gordon loved to do with that bat. He loved to hit his younger brother with this little inflatable bat. And eventually he was hitting his poor little brother, Eric, repeatedly. And his mom was frustrated, saying, Gordon, if you hit Eric with that bat one more time, I'm going to take it away and you won't see it again. So young Gordon pauses and then thoughtfully hits his brother with the bat one final time and then hands the bat over to his mom. And the reason why this story is relevant is that, young Gordon technically followed the rules, but it was really not within the spirit of what his mom said. And when we look at what privatization is in Canada in the year 2025, I feel like there's a lot of that happening, where maybe because of perceived ambiguity in the Canada Health Act, corporations are taking advantage of any possible excuse to be able to charge patients, even though it is obviously not in the spirit of the Canada Health Act and makes no sense from anyone with the smallest amount of common sense. So I'm going to talk about 4 areas where Canadian Doctors for Medicare has noted concerns, and then also actions that we've been taking to try and address those. The first area has to do with nurse practitioner provided care and how for a while it was a big gap in our system. Now, if we think back to the Canada Health Act, it was originally passed in 1984, and the role of nurse practitioners in our healthcare system looked very different. Because they didn't have a crystal ball in 1984, I don't think they could have anticipated what a prominent and important role nurse practitioners would have in delivering healthcare in Canada here in the 2020s. So because of that, the Canada Health Act does specify that there has to be public coverage, just like Natalie was saying, for medically necessary physician services. However, some corporations would read this and think, well, a nurse practitioner can do a lot of services like a physician can, but they're not a physician. Therefore, we can charge privately for services. And even in my hometown here in Ottawa, just a couple of years ago, there's a clinic opening up that would charge $400 a year for nurse practitioner provided primary care. And I want to be clear, I'm not blaming any patients who paid for the care. Honestly, we have such a crisis in primary care right now. $400 a year seems like a comparative bargain for people who are languishing on wait lists and just were suffering and couldn't get care. I think where our concern is that this care should be covered under the public umbrella. If nurse practitioners are providing primary care similar to what a primary care physician could provide, then really and truly, we shouldn't allow this disparity. So I know that this concern was shared amongst many of our allies and many people here. A big focus of advocacy at CDM was working on this Canada Health Act interpretation letter. So we met very regularly with staff in the former Minister Holland's office for 18 months or so. We also co-hosted a press conference with major support from the Canada Health Coalition. So thank you for Anne and Stephen for attending that, to try and bring light to this issue and the fact that this interpretation letter could clarify that yes, physician services provided by non-physician providers should still be covered under the Canada Health Act. We were actually quite excited to see that on January 10th of this year, Minister Holland did issue the Canada Health Act interpretation letter and specified that nurse practitioner provided care and other physician equivalent services provided by non-MD providers will be brought under the public umbrella starting in April 2026. This means that patients should be able to access nurse practitioner care without necessarily having to pay out of pocket, and provinces and territories will need to step up to close this gap that we had. Now, not a perfect solution. We still have time to see how things will unfold. At the very least, I think it's important to recognize that this was a big area of disparity and we're seeing movement towards fixing it. This brings me to my next point, though, in that there is one major omission from that Canada Health Act interpretation letter that we are still very concerned about today, and that is virtual care. Again, when we think back to the Canada Health Act in 1984 and the state of virtual care, I mean, if we look at video games like Pac-Man in the 1980s, very different from video games today, very different from the technology that we have to be able to deliver healthcare in virtual modalities. And unfortunately, just because the Canada Health Act didn't have a crystal ball to exactly specify that medically necessary physician services should be covered regardless of whether or not they're on Zoom or phone or instant messaging, some corporations are taking advantage of that lack of explicit mention to try and charge patients directly for virtual care. And I do think that this is one area in our healthcare system where we are seeing a two-tiered system. Now, the pandemic did change the landscape a fair bit. We obviously saw during the pandemic that a lot of healthcare was shifted to virtual modes of delivery to try and promote our social isolation and social distancing. And now most provinces and territories fund certain degrees of virtual care. However, it's far from complete, and we still have these private for-profit corporations that are essentially charging for virtual care wherever possible. And this is getting increasingly hard, I think, for them to justify. We were really disappointed to see that the interpretation letter didn't provide that explicit clarification to kind of shut this down and make it clear that care is care. And it makes no sense whether or not you're seeing a doctor in person or virtually, that you would have to pay for one of those, but not for the other. Unfortunately, we did hear that there was really fierce lobbying from these private for-profit corporations that wanted to maintain their ability to charge people for virtual care. Same thing from private insurance companies that could also charge their beneficiaries or their folks who are covered under their insurance for the virtual care. So we're continuing to meet regularly with staff from the new Minister of Health's office, and we're optimistic that we can keep this conversation ongoing. We do meet regularly with folks from the Canada Health Act Division of Health Canada. And we're also encouraging everyone here to try and provide pressure at the provincial and territorial level too, because it's helpful to have that federal guidance to say, look, you have to cover virtual care, care is care. It makes no sense that we have this big gap in our system right now, but provinces and territories could decide to fund virtual care at any point in time. They just haven't. So one great way to fix it all at once would be to have that federal leadership. But in the absence of that federal leadership, we can't have provinces and territories deciding to say, look, we are funding virtual care through these different modalities, regardless of whether or not it's instant messaging or phone or computer, et cetera. Therefore, you lose a business case for trying to charge people privately for it, and we can fix this two-tiered system that's been developing online and essentially putting doctors behind paywalls. Another area where I think we're really seeing intentional obfuscation or lack of clarity around what's covered is bundling of insured and uninsured services under a subscription model. So a great example that occurred back in 2022 was a TELUS Life Plus program out in BC. And there was a private investigator, Mike Campbell, who contacted the program to see if he could access physicians through the service. The Life Plus program advertised that it had preventative, uninsured health services like dietitians, kinesiologists, and wellness services. And right now, a great deal of that care is not covered in our system, and it is in our current system acceptable for people to have to pay for care. Now, they also had 25 physicians on staff. So Mike Campbell asked, could I see a family physician without paying the program fee? And they said, nope, absolutely not. Everything comes as a bundle. He was told, in fact, that if he wanted to sign up to be part of the program to receive both the insured and uninsured services, he'd have to pay $4,882 for the first year and then $3,882 for subsequent years to access all these fancy preventative health services as well as medical services. They very explicitly advertise the physician services on their website too. Their website said we have 24/7 physician coverage and that your healthcare team would include a personal physician. So the BC Medical Services Commission, I think likely due to a lot of great advocacy from folks out in BC, really looked into this and actually issued a court injunction against TELUS Health to bring them to court to say you cannot do this. You are explicitly charging people for physician care. And thankfully, TELUS Health changed the program, and now it's been deemed in compliance with the Medicare Protection Act. So they separated out those physician and non-physician services to a degree that the MSC is now satisfied. So I think that's a big win from advocacy, probably from many people who are in this virtual Zoom room, and something that we should celebrate. However, by no means is the TELUS Health Life Plus program the only example of this. There's numerous examples all across the country of these bundled insured and non-insured services. Sometimes they're branded as executive health programs. CDM does meet regularly, as I mentioned, with the Canada Health Act Division of Health Canada. Now, these are public servants whose job it is to essentially oversee the enforcement of the Canada Health Act. And when they hear concerns, like examples like TELUS Health Life Plus or other similar examples, they then follow up with those provinces and territories in question and say, hey, get your house in order. You cannot have people charging for this medically necessary care. Otherwise, you could lose out on federal health transfer payments. And this does happen to provinces where they will have less healthcare funding as a result of allowing violations of the Canada Health Act to occur within their province or territory. So we do have a way for individuals who have concerns about practices like this to report directly. If you look on our CDM or Canadian Doctors for Medicare website, we have a section called the Canada Health Act, and we have a form where you can contact us directly with your concerns. We also have contact information for all the provinces and territories directly. They love to hear directly from patients who have been affected. We are very happy to be that voice using the channels that we have access to bring forward concerns. But it's always more powerful if you are a patient who has been charged, who's been told that you've been charged, to follow up here. It is a little bit tricky with regards to the upselling that we were talking about earlier. There's not as much protection against upselling right now in our system, which is quite a shame. But for these bundled insured services, this is absolutely a channel where we can and should report as much as possible. We've seen action with the TELUS Health program, and I'm sure that we can see action with the others. It's just a matter of playing whack-a-mole and trying to address them as they come up. People will keep trying to slide these techniques in to try and make some money before they're caught. And it's quite unfortunate because it ultimately draws away physicians from providing the higher value publicly funded virtual care, just like Andy was alluding to. And last but not least, I don't want to go on for too long, but private equity is the fourth area where we at CDM are seeing increased corporatization and financialization of our healthcare system. So you're going to hear about private equity from somebody who is very much not an economist. I cried during some of my economics courses during my master's degree, to be quite honest. Very fascinating subject, but very challenging. So essentially, private equity companies have a model where they try to buy other companies and then quickly turn them around and sell them for a profit. Now, you can imagine that if you're having a quick buy and sell, rather than a buy and plan to hold and make money and grow, but buy and then quickly flip it, almost like somebody who flips the house rather than living there, that does not lead to stable provision of healthcare services. In fact, in the States, they've seen several hospitals going bankrupt. Private equity companies can also borrow money for this purpose using their purchase as collateral. So that way, if they try to make money off of the clinic and then the clinic's not profitable and they have to declare bankruptcy, that clinic can essentially close. It's also a bit less transparent. Publicly traded companies need to share a little bit more information and data about their sales, whereas private equity companies can operate a lot more autonomously. Not to say that there is anything untoward happening, but I think that in healthcare, transparency is really key. It's a really important business where it's really clear where everyone knows where the money is going, how data are being used, and we just don't have those same protections for private equity. So right now there is a network of, I think, about over 50 private for-profit surgical clinics across Canada that are owned by a single private equity firm. We see private equity encroaching a lot into other areas of healthcare like veterinary care. It is running rampant in the United States. And there's not a lot of legislative protections now in Canada that can help bring this into force. So we're still learning more about it and trying to encourage the policymakers that we work with to be aware of this issue and to start thinking about possible levers that we can use to essentially quell the influence of these private for-profit corporations in the healthcare space. If you want to learn more, I know that's a very high-level overview. We do have a great position statement on our website, Canadian Doctors for Medicare. Underneath our resources, CDM policy documents. This was drafted by one of our great board directors, Dr. Henry Annan, and had a lot of input from others on the board. And in just 2 pages, I think it very succinctly explains what private equity is and why we're concerned about the issue. I did briefly, before I finish my remarks, want to give a short shout out to the other CDM board directors who are on the call, Dr. Edward Shia and also Dr. Joe Lexchin, I think are constant supporters of the CHC. And then our national director, Zarif Ahmed, is on the call as well too. And I think I recognize a few names in the attendees from our own webinars and members and supporters. So thank you very much, everybody, for your energy. And I'm hoping that together we can really not let these things slide and make sure that the Canada Health Act is truly respected both in spirit and to the letter.
Thank you very much, Melanie. And now we're going to do a little bit of interaction between our panelists, then we'll open it up to a list of questions now. I think we have about 18 comments, including one from Dr. Michael Rackless, a member of the Canadian Doctors for Medicare, a longtime friend and supporter of public health care. So Natalie, I wondered if you could just address the question of nurse practitioners, because we spoke to the Canada Health Act directorate, the people who enforce and will advise to keep money back not too long ago. And they're very kind of careful and non-interventionist in their presentation, but they did talk a little bit about nurse practitioners. I wonder if you could jump in on that, and then we'll go to the questions from the attendees.
Yeah, thanks very much for this. And I'm hoping we can ultimately get on the same page about this, but in the Canada Health Act, there are the 5 principles that underlie public Medicare in this country. And one of them is the comprehensiveness principle. So it's portable, accessible, et cetera, and comprehensive. And the definition included in the Act says that in order to satisfy the criterion respecting comprehensiveness, the health insurance plan, so that's OHIP or MSP in BC or RAMQ in Quebec, et cetera, must ensure all insured health services provided by hospitals, medical practitioners or dentists, and where the law of the province so permits, similar or additional services rendered by other health practitioners. That's the section that covers nurse practitioners. So when provinces transfer what used to be physician services to nurse practitioners, we have always argued that it is covered by the Canada Health Act clearly, not that it's ambiguous or unclear or let them slide away from saying that it isn't covered. And in fact, in Ontario, we brought in the first nurse practitioner-led clinics in 2010. So sorry, I've been around forever, and this is, some history that people wouldn't necessarily remember. And this was a great thing. They're nonprofit, they're paid kind of like community health centers in the public system and not extra billing patients. This nonsense over the last few years in which the provincial government claims that they have to figure out how to provide some way to fund nurse practitioners, utter nonsense. We've been doing it for a decade and a half in Ontario, and other provinces followed suit when they brought in their nurse practitioner clinics. They've never been allowed to charge patients directly for services. They should never be. The fact that that interpretation letter from the federal minister says now we have to wait till April of next year before they start to enforce the Canada Health Act on those clinics gives the provinces enough time to, as Andy was describing, fund and build a private marketplace, and then we have to fight to try and get it out. And that should never be. So just to be clear on that, the other one is bundling or commingling. In Ontario, at least, you cannot make the receipt of a medically necessary service contingent on paying for a medically unnecessary one. So think colonoscopy. You can't require someone to pay for a dietitian to get their colonoscopy. You go to a private hernia hospital, there's only one. Here, you cannot be required to pay for physio in order to get your hernia surgery, and you shouldn't be paying for physio anyways, inpatient in a hospital. So just to be clear, those medical clinics that are selling memberships for thousands of dollars, we got a legal opinion. I'm going to say back in 2007. I'll find it and share it in the chat, but and it says very clearly, you cannot require someone to pay a membership fee to get access to primary care, primary health care. That is your family doctor, family medicine, et cetera, et cetera. So the problem is those clinics, when we phoned them and said, hey, we're a patient, we don't want to pay your fee, but we want an appointment with a doctor. That's how we catch them violating the Canada Health Act. Because if they say no or won't give you an appointment for free, they are in violation of the act. But of course, the whole setup for those boutique physician or those CEO kind of physician clinics is, you know, to be set up in the richest, the wealthiest neighborhoods in the country, where they have a clientele that can pay $3,000 a year or more for access to healthcare in violation of our Medicare laws. I hope that's clear.
Natalie, are you saying that in Quebec, where there's like lots of these private chains that charge $4,000 or $5,000 a year in membership, I could call and say I'd like an appointment, and they would say, okay, you've got to pay X amount of money. I could then report them for violating the Canada Health Act?
100%. That's what, when we won public Medicare in Canada, that's what we won. And, you know, they are not allowed to do that. And I'll find, it was the Copeman clinics when they tried to move into Ontario and start doing that. George Smitherman was the health minister. We got a legal opinion. It was on the front page of the Toronto Star. We were able to stop them back at that point. And so that is, you know, nothing's changed. It's still valid. It was an opinion under the Canada Health Act. And in fact, part of the reason why in BC you have the Commitment to the Future Medicare Act, in Ontario we have provincial laws as well that are super clear, saying you cannot charge a patient, period, for an uninsured service, for an insured service, sorry. So like for an OHIP covered service, for an MSP covered service, you cannot charge a patient, period. And in those, there are fines and so on that are supposed to happen.
I just mentioned to attendees, there's some interesting material being dropped into the chat, some links and suggestions for reading material if you're looking for more information, including material that Melanie mentioned that the Canadian Doctors for Medicare have done on equity in medicine, and also access to their webpage for complaint procedures. So there's possibilities of making, we just wrote a piece which we put in the chat about how to complain. We would strongly encourage people to do that, first with your provincial minister, then with the college of whoever is overseeing the offending person that you feel has done wrong, and then with the Canada Health Act, with Health Canada itself. And Natalie and the Ontario Health Coalition have sort of led the way with a roster of 50 complaints specifically about cataract surgery. I just wanted to mention, there's a question here from Nick Sergis, who is the person behind CanadaHealthWatch.ca. And he's a health journalist and friend of ours. And he's asking what our experience has been with the Carney government and the new federal health minister, Marjorie Michel, who is virtually invisible as far as we can tell, regarding private pay issues. So I wondered if anybody on the panel wanted to talk about what it's like talking to the new minister, because comparatively speaking, it seems like Mark Holland was fairly hands-on and relatively attentive to issues related to public health care. So let's go to you, Melanie. What's been your dealing so far with the minister?
Yes, we've reached out to book a meeting, have not yet heard back, which is not unusual. As mentioned, we do meet with Minister Michel's staff, and we've had really positive first few meetings there. I do think, maybe it's just the optimist in me, I think it's too early to say. We also went straight from an election to the summer session, so I think it'll be a little bit, we'll have a better idea with time what direction Minister Michel is going to go in with. But for anyone who works in the advocacy space, I know this is probably very familiar to you, meeting with the direct parliamentarian or the minister is really special and important, but it's the staff that gets stuff done. And if you can get the staff on your side, you will affect change that way. So we'll meet with anyone who will meet with us from any party, but I think our most productive meetings have been from the staff who actually have the time and oftentimes the educational background to ask very detailed questions. So I'm optimistic that we'll be able to meet directly with Minister Michel, as we did have a good relationship with Minister Holland. I did want to clarify something too from Natalie's perspective. CDM has always agreed that there is no actual loophole in the Canada Health Act regarding nurse practitioners. We think that is airtight, but people were charging anyway. And it begs the question, what is going to be the next ridiculous loophole or ambiguity that corporations are going to charge? Are they going to say, well, we can start charging on Tuesdays because it doesn't mention the days of the week in the Canada Health Act? It's getting to be a little bit ridiculous with regards to the virtual care piece as well, too. I think anyone with common sense could see what the spirit of the act intends. And it is unfortunate that we've gotten to a place where, because corporations were essentially not allowed, I don't know, just maybe not addressed early on enough and making money off of these situations, now we have to retroactively go back and explicitly state what's permitted and what's not permitted, even though, at least from our perspective, it's always been clear in the Canada Health Act. So I think there's different strategies we can use. Also, just working with Health Canada and trying to encourage them to take action when there's those perceived challenges against the spirit of the act, I think is another good tactic that we try to do.
Melanie, while we've got you on in focus, Heather Kelly has a question in the Q&A. Why have so many doctors gone into private practice? What's happening with your colleagues? What's going on with them?
Yeah, excellent question. I think it varies so much by province, by specialty, and also by the individual. I think in terms of the virtual care, it can provide a very appealing lifestyle, very flexible hours, very short hours, very low stress care. It's very rare that you're going to significantly, obviously, harm somebody by providing virtual care. And if you do have any concerns, you can just tell them to go to the emergency department. The public system will end up taking care of them. So I think it's a much easier job. And I don't mean to be flippant. I recognize that the practice of medicine right now is incredibly challenging. It's something that's immediately clear to me every day as I work in the emergency department and face these long wait times. I think that we're also seeing a lot of lack of support for primary care. And so many people are struggling to get family physicians because family physicians do not have many options on the way they're paid. They're trying to run a small business in impossible circumstances. Frankly, they're probably not paid enough and probably not valued enough. And a lot of their work that they have to do is unfunded. They're often working in silos without the benefit of a whole healthcare team, like how I have at CHIA, where I have nurses and other physicians, specialists that I can get in touch with, crisis workers who can do long assessments for patients coming in with mental health. We need to ensure that every family medicine practice has access to that same kind of multidisciplinary team. And I think that that is what would entail people to try and stay more in the public system.
Okay, did anybody else want to comment on communication with the federal minister and her staff? Natalie or Andy?
I'll just, not so much the communication, but I think I think we are at a moment historically in terms of the future of public healthcare in this country, where I think we need to start talking about the actions that we're seeing and the behaviors as fraud. And folks like Don Berwick, the former administrator of the nonprofit Veterans Administration, a large health system for veterans in the United States, and a champion of not-for-profit healthcare and quality improvement. He talks about a culture of greed in healthcare. And I think we need to start talking about that culture of greed that we're seeing, like Natalie mentioned. It is a pervasive culture of greed that we're seeing emerge in this country. And it's not a surprise. We are at a time of rampant inequality globally and in this country as well. And so as we see elite power in forms of corporate power increase and crowd out the ability of communities and civil society and unions and organizations to basically balance out and challenge the power of corporate greeds and elites, we are seeing this unchallenged rise of greed in healthcare. And so I think we need to call it out for what it is. And I think we need to put pressure on governments at every level to start litigating and enforcing our legislation using the criminal code if necessary. And I think we need to name and shame. We need to call it what it is. And we need to say this is driving poor access, longer wait times, and pulling the workforce out of providing the necessary care that all Canadians have a right to. And all of those in our provinces who are struggling, as Melanie says, with access to primary care. You know, the interesting thing about the experience in BC with that that subscription-based TELUS service is the investigation and the audit by the Medical Services Commission provided great empirical evidence of exactly what this does to access. It was pulling physicians, family physicians who provided ongoing longitudinal care and had a roster of over 1,000 patients. And it was pulling, those physicians were being attracted to work under the TELUS banner and providing care to, I think it was around 200 to 300 patients. So you can see pretty quickly how this movement, which is driven by greed, is going to be reducing access and increasing wait times for everyone who depends on public health care. So I just want to throw that in the mix. I think we need to talk about this as a form of greed, a culture of greed, and it needs to be treated as such because it is emerging as a problem of fraud and defrauding Canadians who have a right to access health care.
I was
If I can,
sorry, 1 second, Natalie. We had a comment from Ivan Stephen amongst the attendees who said exactly what you just said, Andy, which is that this is a form of fraud. And and Ivan Stephen is saying, so when will the police get involved? And I mean, that seems like extreme, but I think you're right about the culture of greed. Like we need to be just a little bit more gloves off on this, I think. I would agree with that from what I've seen. Anyway, sorry, go ahead, Natalie.
No, it's perfect segue because I was also going to say, like the solution here it's never been and it's never going to be very technocratic. It's a pressure war. It's the public interest versus the private interest. And we have to ante up, we have to ratchet up what we're doing to pour on the pressure. So whether we like or don't like the federal government is really not the relevant point at this point. They need to feel as much pressure from us as they're feeling from the forces that want them to increase the military budget to 5% of GDP and so on. It needs to be a national priority to crack down on, what's happening is these are mostly elderly people, right? Not just elderly, but also people with chronic illness, people who are sick, who are unable to work, people who are elderly and dying and unable to work. And they're being charged literally thousands of dollars for their healthcare and private clinics across Canada now. That's a huge loss of what we won a generation ago, and we can't let it go without a major fight. So I'm with Andy and Melanie. Both the inside strategy, the lobbying and all of that is great, and we need to sort of have a common position and not let slide some of the definitions, or we will give them the out that they want to not have to battle with the provinces right now over enforcing the Canada Health Act when they want other things from the provinces. And at the same time, we have to mount massive public pressure, really serious public pressure if we're going to win, which also we're going to try to do next week.
Well, I think because we're getting up against the clock, which always happens, we're going to have to do several other forays onto this playing field, as Andy mentioned, and we're going to maybe have to up the ante now that we have a prime minister who's openly talking about massive cuts across the federal public service that will escalate in the amounts being extracted over the next 2 or 3 years. I wonder, Natalie, if we could close by just a little mention of what's planned for Huntsville next week.
Thank you. Well, remember that the birth of the private clinics in Canada came at just, 1995, after 1995, and the big federal cuts to transfers. These are the private surgical and diagnostic clinics and have grown since then. And so, very, very dangerous time indeed. Next week, the Council of the Federation is meeting. So the Prime Minister is going to meet with the premiers in a First Ministers meeting. And in addition, all the premiers and territorial leaders will meet in what's called the Council of the Federation meetings. The Council of the Federation, they're going in on the 21st, which is Monday of next week, to the 23rd at Deerhurst in Huntsville. We're going to hold a shadow summit on the 21st with workshops on all of these issues: virtual care, charging patients for healthcare, privatization, best models for home and community care that are public and accessible. This kind of whole gamut of issues. What's happening with de-staffing and for-profit staffing agencies across the country, the opioid crisis and mental health, and so on. So a shadow summit on the 21st, Monday, at the resort, which is like a hotel-y kind of place next door to where the premiers are meeting. And there's all kinds of cabins and camping and all that stuff all around there. It's right near Algonquin Park by Huntsville. And then on the Tuesday at noon, we're going to do rallies and car cavalcades to raise these major healthcare issues while the premiers and the Prime Minister are meeting. So that's Monday the 21st, Tuesday the 22nd.
Right. And that, to me, my old activist heart just gets a big charge out of hearing that's going to happen. So anybody who's looking around for something to do, or maybe something vacation-y, that would be something to think about. And I guess I would like to ask my colleague Tracy if she can include some of the links that are in the discussion for people who are attending today, because we're going to have to end in just a minute from now, but we will be back to talk some more about this and about the complaint procedure and other activist approaches to this, because I think that's where we're at now with this particular government in place, and the mostly so far invisible health minister, Marjorie Michel, who was elected in the Papineau riding. And I do apologize to those who asked questions, because there's so many good ones, but there's so much material to cover. I think maybe we're a bit overly ambitious with this webinar, but we will definitely be taking another run at it, and in great enthusiasm for the numbers of people who turned out today. Thank you very much for joining us. Vraiment, on vous remercie du fond du cœur. I'm sorry we didn't get to all of the questions and topics, but we will be back on this fairly shortly after everybody gets a little vacation and maybe goes up to Deerhurst to make their opinion to the premiers and the Prime Minister. And a big thank you to Andy Longhurst, Natalie Mehra, and Melanie Bechard. We love you and admire your work so much, and we thank you deeply. And a big thanks to the activists and people who've joined us today online, and we will be talking further about this, and we know that people care deeply about this, so we will not be dropping the ball. So thanks to Tracy Glynn for stick handling this, and we'll talk to you again soon. Merci et au revoir.